All right, good morning, everybody, and welcome to today's webinar with the Accountable Care Learning Collaborative. This is Tom Merrill, and I'll be moderating today's webinar, Getting Your Priorities Straight, Helping High-Risk Patients. We're excited about today's presentation and the opportunity to hear from Catherine Mather, Director at the Institute for Healthcare Improvement. We are also joined by Corey Waller, Senior Medical Director for Education and Policy at the Camden Coalition of Healthcare Providers. As you saw in our webinar invite, we'll be talking today about IHI's Playbook, a resource for organizations seeking to improve care for the high-risk population. IHI has been a trusted friend as the ACLC has been growing. We have looked to them frequently because of all the great things that they've done, and we're excited to have them join us today. We'll also be joined by Corey Waller of the Camden Coalition, who is a group that has done just a lot of good work, both locally as an ACO and on a national level. And we'll be discussing a little bit more of their work today. So a very great combination. So real quickly, we have a couple housekeeping items. We will be reviewing slides. So if you are able to join the Zoom webinar on your computer, please do so. If you are only able to connect by phone, don't worry. We'll send out the slide deck after the call along with the recording. So, and then as a reminder, there will be an opportunity to ask questions in the last 15 minutes. So please submit them using the question module in the Zoom application, and we'll kind of put those in the queue and get to those toward the end. So we will plan, okay, so actually let me just review the agenda real quickly. We'll talk about a few ACLC updates, then I'll introduce the guest presenters. We'll have the actual presentations, and then, as I mentioned, a time for Q&A. So our next webinar and our next member event will be on September 6th. Integrating capitated payment arrangements and ACOs, looking at successful global payment projects. This is going to be a fantastic webinar. We'll be joined by Brent James, quality guru over at Intermountain Healthcare. So I'll mention a little bit more on that later. Look for details in the weekly news. So registration, email, etc. We also have August work group calls, calendar invites will be coming soon. And finally, as you look forward to your fall schedule, remember that the ACLC member meeting will be happening in Washington, D.C. on October 4th. So mark your calendars. So our first presenter will be Catherine Mather, as I mentioned, is a director from the Institute for Healthcare Improvement. And she joined the Institute for Healthcare Improvement in August of 2011 and serves as a project director. In this role, Catherine is responsible for the successful planning and execution of a portfolio of projects within IHI's triple aim and person and family-centered content areas. Prior to this role, Catherine worked as a new business manager at IHI, facilitating the design and development of new partnerships, programs, and products in North American region. Before joining IHI, Catherine worked on Health Dialogue's consumer segmentation and engagement strategies team, where she designed targeted member engagement strategies and award-winning communication materials. Catherine, we're so glad to have you with us today.
Thanks so much, Tom. It's great to be here.
So we will also be joined, and I'll just give you Corey Waller's bio at this moment as well. So Corey Waller of the Camden Coalition is an addiction, pain, and emergency medicine specialist, and is now the Senior Medical Director for Education and Policy at the National Center for Complex Health and Social Needs, also at the Camden Coalition of Healthcare Providers. In this role, he is responsible for developing and maintaining all training and live technical assistance delivered by the National Center. Before joining the National Center and the Camden Coalition of Healthcare Providers, Corey worked for the Spectrum Health System in Grand Rapids, Michigan, where he was the medical director of the Spectrum Health Medical Group Center for Integrated Medicine, the medical staff chief of pain medicine to the Spectrum Health Hospital System, and the president of the Michigan Society of Addiction Medicine. Corey, if you're there, welcome.
Thank you. Happy to be here.
All right, and at this time, I will turn it over to Catherine, who will then turn it over to Corey. Catherine?
Great. Thanks so much, Tom, for that kind introduction. And I'm really thrilled to be here today to share with you all a resource that we've been working on for the last 14 months that we call the Playbook, Better Care for People with Complex Needs. And just to note, while IHI is the lead developer behind this, this project is supported by a really great funders collaborative that includes the Commonwealth Fund, the John A. Hartford Foundation, the Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And we've been fortunate enough to be able to really collaborate with all of them on the development of this tool. So just to start, this came out of a movement from these, so we call them the 5F Collaborative. I think that all of us on this call have probably heard the statistic about 5% of individuals accounting for 50% of the healthcare costs. And I think furthermore, these individuals aren't receiving high quality, and safe care. So these 5 foundations realized that they were all funding work in this area, but kind of operating in their own silos. And so decided to come together to see if combining their influence in the field could help to move the field forward more quickly. So up on the screen right now, you'll see a screenshot from a perspective piece in the New England Journal of Medicine. And this was co-authored by the CEOs of all 5 of these foundations. And in this, they publicly state that improving the performance of the health system starts with improving care for those individuals who need it the most. So sometimes called high-risk, high-cost patients. We tend to prefer the term patients with complex health and social needs. So they publicly stated that here, and also made in addition to the financial case, made the humanitarian case as well, especially citing that patients with complex needs are more likely than others to be affected by preventative health, quality, and safety issues, just given their frequent and often uncoordinated interaction and contact with the health system. So in this perspective piece, they outlined 3 key steps that they felt they could contribute to improving care for patients with complex needs. So facilitating the deep understanding of who exactly are these individuals with complex health and social needs, and then identifying evidence-based and also promising programs that are shown to increase care and reduce costs for these individuals. And finally, the third step is to help organizations accelerate and adopt some of these, help organizations accelerate the adoption of proven practices to redesign care. So what you can see up here right now is the overall aim of the 5F Collaborative, and it's very bold. It's by 2020, 30% of ACOs, Medicare Advantage plans, and other value-based payment organizations have adopted proven interventions for high-need, high-cost patients. So, the Playbook is just one piece of their work together, one tangible step toward improving care for this population. So just a little bit about the Playbook itself, and I am going to do a quick demo later on in my talk. But right now, the Playbook has over 115 highly curated resources focused on the topic of improving care for patients with complex needs. But when we started in July of 2016 and launched on December 9th, 2016, we really started by focusing on about 80 resources that had been funded by members of the 5F Collaborative. And what we did is we took that body of work, which was really incredible, and went through and completed a detailed review, evidence analysis, and curation process for all of those resources. And how we landed was on 4 key questions facing leaders trying to move this work along. Why invest in redesigning care for people with complex needs? Who are people with complex needs? What care models are promising? And what are the key elements of redesigning care? So that launched on December 9th, largely with the resources funded by the 5 foundations. What we've been doing in 2017 is, while that was an incredible body of work, there's additional work going on in the field. So part of our work in 2016 was to identify some of the major gaps that existed on the playbook. And we've been spending 2017 doing some detailed research to fill in the gaps and adding resources beyond the 5S collaborative. You know, I should note that we are not doing this alone. We have a really fantastic advisory group that we're working with. And we also have faculty chairs for each of the 4 key questions. Corey Waller, who you'll be hearing from later, is one of our faculty chairs for the key elements question. And he's also been our advisory group since the very beginning. So we owe a lot to those individuals to be kind of our sounding board to make sure that what we're doing is really balancing the need for having a comprehensive resource that provides the right information, but also maintaining the value of it being highly curated and easy for users to find exactly what they need. And one other note is we're really thrilled. Just about 3 weeks ago, we launched what we call Play by Play, which is the blog on the playbook. Again, I'll give a demo in a little bit, but this is a way for us to actually include some content that's original to the playbook. So just a few of the vital statistics. I'm not going to read through all of this. You can take a look here, but just a couple of things I want to call out is that we're particularly excited about is that the playbook users that have been visiting are really highly engaged. Right now we have about a 50% return rate, or 45% of visitors are new. And also we're seeing that folks are staying on the playbook for a long time, about 4.5 minutes per visit, which from what I understand from our web developer is really a remarkable length of time for a website like this. Another thing that's really great is that once users do click on a resource within the playbook, 50% of them click out to go find more information about that resource. So we've been really pleased to see the level of engagement on the site. So some of the key challenges that we're facing with this project, and I'll just call out a couple here, but you know, as I noted, we are trying to get the best of the best in terms of resources up on the playbook, making sure that it's very well curated. And, you know, unfortunately, some of the promising models and tools that we're hearing about are from the private sector and can be a little bit difficult to identify and share publicly. So we've been working on forming some partnerships within the private sector in order to bring some of that content to the playbook. And then, you know, another thing that we're trying to, it's down here as a challenge, but it's really an opportunity, and we just want to make sure that we are doing everything that we can, that the playbook not only is a source of dissemination, but also is a way to inform the health services research priorities of the 5 foundations, where we're lucky to have such a strong partnership with these 5 organizations. So how can the playbook help inform their research and funding priorities? And I wanted to just share a couple things that surprised us as we were working on this, particularly from phase 1. We realized that there's really a huge gap, or you could think of it as a huge opportunity to better incorporate patient and caregiver perspective, as well as community voice and partnership in this work. We really noted that there was a lack of an articulated patient caregiver voice, and also the community and partnerships, which are really critical to this work. Finally, you know, we wanted to note that there is really a lack of resources that address health equity, which is very important to this area as well. And I think noteworthy that really none of the resources that we were able to find actually stratified data in terms of health equity. So working through this, we kind of came up with 5 priorities for leaders, and I thought this seemed like a great group to share this thinking with. You know, the first is that patients with complex needs, they are not a homogeneous population. There's just a number of different subpopulations within this group. So, you know, we'd encourage leaders to study and test care models that have been shown to have promising results for the specific subgroups that you're focusing on. And when I go through the demo, I can show how the resources on the playbook are organized in that way. You know, we've also heard from the field that there is a huge desire for some more granular real-life case examples. I think that well-planned and deployed research designs would be of successful models would be a welcome addition to the field. However, we can't afford to wait for that. Right now, we'd encourage organizations to share frequently and loudly what's working and what's not as they try to redesign care so that we can all learn for each other. And our vision is that the playbook can be a source for that sharing. Another note is that the evidence for the business case is lacking, and the resources that do exist tend to focus on a single dimension of care, whereas real cost savings in this area is much broader than one portion. It crosses many sectors of healthcare, but also outside of healthcare into society. So one solution to that is potentially looking for innovative payer and provider partnerships that could help to accelerate that understanding and shared learning. Finally, as I just spoke about, there's much more opportunity to engage patients and caregivers in co-design when it comes to these approaches. And then finally, we noted that there is an increasing interest in state-specific programs and intervention, especially as folks that are innovating, as innovations in Medicaid payment models proliferate, where we're just seeing more and more interest in state-based approaches. So now I'm going to just do a very quick overview of the playbook, and I'd welcome you all to come visit at your leisure as well and explore. This is the homepage of the playbook, so you can see the 4 key questions that I spoke about earlier. That's kind of the main organizing function for the playbook. And then if you were to click on one of these questions, you come to a landing page. So each of the 4 key questions has a landing page with some information about that question, and also the opportunity to dig a little deeper into some of these sub-questions. Our hope is that this is organized in a way that helps users really drill down to the information they're looking for as quickly as possible. And this is an example of what the resource summary looks like. So, the resources themselves are everything from randomized controlled trials to, certain gray literature, briefs, even some webinars and reports. So they're kind of a wide variety of resources, but what we strove to do with the playbook is kind of pull together a consistent format about the key questions that the resource addressed, key themes and takeaways. And then if users want more information, they can click on the link to the original resource. And just to note, the resources are also, as I spoke about earlier, are also organized by population served. So we have these 5 populations here, which were adapted from the National Academies of Medicine's recent report and their work group that was working on segmentation of individuals with complex needs. So we do allow users to kind of drill into those populations if that's a better way for them to organize their thinking. And we have a landing page for each of those population types as well. And finally, I just wanted to share a screenshot from our most recent content. You can see that this was posted on August 1st. So we're really thrilled to have the blog up and running on the playbook, which is allowing us to do some really neat things like interviewing some subject matter experts, either in written Q&A, or in this case here, we have a great video series by Dr. Jose Figueroa talking about segmentation for high-need, high-cost patients. So just a couple notes about what's kind of coming soon. This is absolutely a work in progress tool. We're looking for ways to make it much more engaging, and also transition from the playbook being just a source for disseminating content, but also a source for generating some of the best learning and content. So some of the things that we're working on and will be rolling out through the course of the fall is that will include some very practical tools that individuals doing this work can can actually use when they're redesigning care. So that could include things such as different tools for data review, different focus group tools for talking to and engaging patients, examples of agreements and partnerships with community organizations and things of that nature. We'll also later this fall be rolling out user-submitted content. So we're really excited about this, opening it up to Playbook users to actually submit whether they have a resource that they'd like to nominate for the Playbook, whether they have a tool that they've used in their own care design process they'd be willing to share, and also allow all organizations to submit case examples on both successes and I think, maybe even more importantly on failures, sharing things that didn't work so that we can all learn from each other as we move forward. We're also adding in right now, there isn't the ability to log in and comment and rate different resources, but we'll be rolling that out in the next month or so as well. So I would just say, again, I would really invite you all to come and visit the Playbook, and we are looking to constantly evolve it. One of our biggest design principles is designing with the end user in mind. So if you have any feedback at all, please do share with us. You can email playbook@ihi.org or me directly, but we look at that email box constantly and are always looking for a way to make the tool better. So I know we're going to do some questions at the end. I just wanted to say thank you all for the opportunity to talk about this, and I'm thrilled to hand it over to Dr. Corey Waller, who's been, as I said earlier, a great friend and asset to the Playbook. So Corey, I'll hand it over to you.
Great, thanks, Catherine. That was a really helpful overview of the Playbook, and I think really does set us up for what I'm going to talk about, which is not just the conceptual framework of the systems that we can build, but really a focus down on implementation realities and talking about workforce development and things to think about as we develop systems for these patients that are, not really just provided by the fact that we have, different patients, but also different locales and different cultures and many systems that are difficult to deal with in many ways. So first I want to just do a rundown of the Camden Coalition. So the Camden Coalition, it's been around for a while, and I just joined a year ago, but have been working with Jeff and in a lot of his cohorts for about 5 or 6 years prior to that when I was in Michigan. But he started this process in Camden, New Jersey back in 2004, where he, like most of us in this field, were frustrated with the current system. So we tried to figure out from our own frame, what is the best way we can really impact those patients who we feel were falling through the cracks and the systems weren't built for. And so what he did was looked at hospital admission data and found geocoded hotspots in the city, and from that ultimately developed what became a high intensity care coordination model. And obviously this occurred pretty rapidly after the publication in the New Yorker by Atul Gawande on hotspotters, and it went from having really about 12 people primarily about 5 years ago now to, I think the last payroll had about 106 people on it. And we've now, through a collaboration with Robert Wood Johnson, Atlantic Philanthropies, and AARP, have developed a national center for complex health and social needs. So the goal for this is actually to work with everyone working in this space. And as Catherine talked about, IHI had, through this 5 foundation funders, developed a playbook, and that is something that we're not competing with. In fact, we're actually coordinating with them to make sure that there's no redo in this as we develop really what is going to be a blueprint for the system. So let's shift a little bit to what we found in seeing these patients. So interestingly, my system that I developed was in Michigan, and it was an ambulatory ICU in a healthcare system. So it was very different from what Jeff had done. And my focus was on patients in the emergency department 10 or more times per year. And at that time, we didn't look specifically at cost, more just utilization. And as I saw patients for 5 years, and Jeff saw patients in his intervention for 5 or 6 years, and Ken Coburn in Southern Pennsylvania saw his patients, and Steve Martin in Northern Pennsylvania, places in California, all around the country, what we have really been able to coalesce on as no matter where we are and which type of intervention that we have, there are some commonalities that we have found with patients and some commonalities of defect within the system that treats them. And so we'll kind of talk about this, and we need to refocus the medical system on treating the cause and not the effect that we find from that. And let me explain that a little bit. Every patient is born with a genetic predisposition and inherited epigenetics, which means that if their parents are in a certain geography under certain stresses, there are changes that happen to the DNA, and we have found that these can actually be passed on to the newborn. So those things happen, and you're just handed that deck of cards. Well, if you add in what we have found, almost greater than 95% of patients with complex health and social needs is early life trauma. When you add in that little modifier, that changes the whole trajectory of life for them. And what happens is that subset of people who have that genetic predisposition, which is a large portion of the population we're finding, has early life trauma, you get a decreased buffer. And that emotional complexity buffer that they have a decrease makes them feel less safe and does not allow for them to really create what we call authentic healing relationships. And many times, even if they wanted to, they would have difficulty finding them. So that decrease in both physical and emotional safety and that lack of connection to people around you really leads us down this road to a pretty significant increased risk of addiction, mental health, chronic pain, cognitive impairment. And once you have this subset of diagnoses, there's a whole lot of things that fall after that in kind of a waterfall effect. And that once it's gone over the cliff, it's going to keep going unless we intervene. And, you know, addiction is obviously out front and center right now with the opioid crisis, but we keep forgetting that alcohol use disorder eclipses opioid use disorder, both in the healthcare dollars spent on the aftermath of it, as well as just the numerical, the people with it. Mental health conditions, whether it's depression or anxiety or things like schizoaffective disorder, schizophrenia, are common throughout society. And those systems, while bolstered over the last few years, still haven't integrated into mainstream medical care. And the mental health conditions that happen with chronic pain, and obviously the high risk of opioid addiction for patients who are treated improperly for chronic pain, definitely changes their outlook. And then cognitive impairment is defined really as patients who have low IQ or are on the spectrum for autism, because when they have that, if we identify those things early, we can actually have a really positive trajectory for that. I say that with personal experience. I have a brother-in-law with moderate to severe autism who, when I first interacted with him 15 years ago, I wouldn't think that he was ever going to not have to live with his parents, but now lives alone, drives, and works for a living after being identified early and getting treatment. So these four conditions, if treated, can actually stop the process at this point. And we can treat those patients and they can be very productive members of society and stable for their family. But if we don't screen for it, if we don't treat it and we don't intervene on it, then what we find is we have this population with an increased risk of homelessness, and then followed by this increased risk of incarceration. And either one or both of those automatically put somebody at high risk for having these lower three, which is this either lack or inconsistent transportation, unpredictable to get a hold of their provider and vice versa, and ultimately lack of care coordination around them, and whether that's a connection between housing or a connection between just a standard discharge summary and a primary care doctor, those things really start to fall apart. But one of the problems is that almost every intervention that we've developed in modern medicine is directed at these effects. They're directed at diabetes, COPD, hypertension, CHF, sickle cell, whatever the diagnosis is. And unfortunately, you can have the best diabetic educator, the best nutritionist, you can have the perfect endocrinological regimen for a diabetic patient. But if they have untreated addiction or a chronic mental health condition that's not treated or severe chronic pain, they're not going to actually ever get a hemoglobin A1C that makes sense. And we're going to be frustrated. And what we find is the system is actually built to create the patient as an enemy rather than a partner. And so we have to start focusing on those conditions that ultimately are the sentinel conditions for the vast majority of poorly controlled other identified medical conditions. And in doing that, we would then be able to really arrest the progression of the vast majority of these patients to these poorly controlled diabetes situations or emphysematous exacerbations that send them to the emergency department, hypertensive emergencies, out of control congestive heart failure. These are things that we would be able to control better if a patient is housed, if a patient has stable and treated addiction or mental health disorder. One of the problems is that if we look at these conditions, addiction, less than 1 hour of training through medical school, mental health, only about 7 hours of total training, and the one rotation in medical school, but it's definitely not required in residency unless you're a psychiatry resident. Chronic pain, less than 1 hour of training. Cognitive impairment, you're just lucky if you get anything for these things. So these also happen to be the biggest gap areas in knowledge for existing people. So from the workforce development, we're realizing that education is a massive gap, but so is the way in which we work together, which is why the future of treating complex patients, and actually the current in the successful programs, really revolves around this interprofessional and multidisciplinary team. And we always talked about when I was training in addiction and seeing patients that addiction is a team sport. It is not something where I, as a physician, can go and hang a shingle and all of a sudden save the world and see these patients. I need somebody who can coordinate care. I need a therapist for that patient. I need someone who can make sure that patients are safe in the homes in which they live. I need someone who can go out and find them. And that requires a significant team, which in many ways also requires a significant change in the way that we, one, view the interaction with the patient and view the systems we've built, because most systems are currently built in a very hierarchical fashion. Meaning if I'm in a clinic and I'm the physician, what I say goes. I found out very quickly after starting to see these patients in a clinic that I'm one of the least important people in that clinic, and that hierarchy is whomever needs to be in charge that day. But the day-to-day understanding is what is the scope of practice of each of these people, and we have enough overlap so that we can pick up each other's work when we have to. But most of the heavy living with these complex patients doesn't live in the realm of the physician. Because again, unless we've taken care of those sentinel diseases and these other issues like homelessness and incarceration and transportation and care coordination, communication, if we haven't handled those things, again, the smartest endocrinologist is not going to be able to get that patient's diabetes better. So not only do we have to identify these interdisciplinary, interprofessional, multidisciplinary teams, we also have to fill those gaps of knowledge. And in order to really treat complex patients, if you're going to start a complex patient intervention in a health system or even in a primary care setting or an FQHC, then the knowledge base that's required is you have to understand addiction. And quite honestly, if you can't treat it on site, you need to have super high fidelity interaction with an addiction treatment facility, meaning that you have weekly meetings and you talk through your patients on a regular basis. You need to have a really good understanding of how to screen for and intervene on the vast majority of mental health disorders. And I would say you have to have that in order to be successful. Now, for patients with severe persistent mental illness, you don't have to know how to do that, but you're definitely going to need to know when and how to refer and have an interaction with the person you refer to. Cognitive disorders, if you don't know when you need to evaluate for a learning disability or a reading difficulty or IQ issues or someone on the spectrum, then it's going to be difficult for you to identify why someone is not necessarily following through if and when you get the other things stable. So it's important to know when to test and actually what tests to get done. Trauma-informed care is obviously the overarching theme for this, but quite honestly, again, this is an area in which the vast majority of providers, really any of those interprofessional providers, don't receive enough training in understanding what that means and how to build a system of care that is trauma-informed and not thinking it's an individual problem. And then the last one is chronic pain. And chronic pain is different than I broke my arm, I need some treatment for my pain. Chronic pain is, all right, I have horrible lower back pain and it keeps me from going to work and I'm very sad. Well, how much of that is suffering and how much of that is actual pain? What are the other non-pharmacological interventions that we can do for that? And how do we get a patient to, quote, buy into those interventions? Because we have a generation of patients that have been on opioids for over, a decade, and trying to explain to them that that was the wrong thing to do, and we're sorry, here, go do mindfulness and yoga, is sometimes difficult. And so there are real practical realities of having to have that conversation. So what we embarked on, I guess now, 3 years ago with Robert Wood Johnson leading the way and funding, was the development of an interdisciplinary and interprofessional training curricula for everyone who treats patients with complex health and social needs. And originally the idea was to start out with just pretty standard didactic training where we would have a bunch of lectures on topics. But then we realized that, how do you have somebody sit through an hour lecture if they're a social worker and you're talking about dosing of buprenorphine? And how do you have an hour lecture of how to do cognitive behavioral therapy in a patient with addiction and have a prescriber sit through that and feel like it's relevant? So what we did is we exploded the whole idea of how we're going to train people, and we came up with these gap topics. And again, those are those sentinel diseases: the addiction, behavioral health, cognitive disorders, chronic pain, and broke those out into a bunch of different topics that live within those subjects. But then we did overview videos, so just a 15 to 20-minute video. And from that, we figured what we need to do now is have people learn how to actually apply it to people and not just have a conversation about a topic of how to write for an opioid or cognitive behavioral therapy or chronic migraine headaches. And what we did was we developed 7 archetypal patients. And those 7 archetypal patients give us the ability to be very specific about what we're doing for specific people. And we broke that out into specific parts of their life. And so adolescents, early adults, and late adults. So now, if you're a part of that interprofessional or interdisciplinary team, you can go to that website, sign up for free, put in your level of training, and then that level of training will then build you a curriculum based on that. So you're not having to watch those things that are not specific to your needs. And so with that, we're hoping to be able to really fill those gaps in education for the workforce so that as we develop the systems that we pull from the playbook, we can then start to put together here's what you should do, followed by here's how you do it. So with that, I think leaves us a good 20 minutes for questions, and be happy to take any of those. And I know Catherine would as well. So thank you.
Okay. You guys hearing me? Okay, Corey, thank you so much for your time, or for your presentation, excuse me, and Catherine as well. So yes, let's jump into Q&A. There are some coming into the queue, so we'll look at those as those are coming in. So I'll remind you that is the place to submit those questions. I will take moderator's prerogative and ask just a couple real quickly. So Catherine, I think the work that's being done by IHI and in collaboration with your with the foundation group is just it's really amazing, and it looks like an incredible resource. And we are so excited that this was able to be shared with our members, and we encourage you all to explore that. I wanted to ask if you had any maybe anecdotes of organizations that have come to you and said, we are using this, and here is how were using it, even just an anecdote, if you guys have been able to get a sense for how people are using it and maybe in ways that you didn't anticipate?
Yeah, thanks, Tom. That's a great question. Trying to think of a good anecdote here. I mean, we've gotten a lot, I think actually way more than we anticipated, a lot of feedback through the playbook@ihi.org email. And, you know, I think that people are probably the 2 pages that are being used the most by folks are the who are people with complex care page, and then also the what care models are promising. So, you know, I think in terms of anecdotes, what we've heard mostly is that there's a care models grid that's part of the what care models are promising, and we've heard about a lot of organizations just finding that to be a great source for, you know, a one-stop shop to understand some of the most promising models that are out there, and using that to kind of explore what might work in their own setting.
Okay, great. Thank you. Another question I have actually for Corey, and this kind of gets to the interprofessional team. We have a couple questions around this. You mentioned that when you became a part of that team, you came to the realization that you were much, you know, less important when looking at it through this lens. Do you feel like, you know, we've heard of the issue, the sort of reoccurring issue of egos, right, in healthcare, and the hierarchical aspect that you mentioned. How big of an issue do you think that, you know, cultural issues around authority plays? And is that something that you saw in the Camden Coalition, or do you feel like the Camden Coalition just attracted docs that just didn't have those issues?
Well, at the Camden Coalition, I'm the only doctor in the building since Jeff took a job with United Healthcare. With that, but as we look at it, the interdisciplinary and interprofessional teams was really tough, and the ego play is alive and well with the current generation of physicians. And what we have to start to work on is not that you're trying to take away capability or access, but the job of a physician is actually shifting. And in the next 10 years, and I've talked to a number of people in DC and around the country, and I really do feel that we need to retrain some of the existing docs, but then definitely continue to train now that interdisciplinary teams is the rule and not the exception. And you can apply it as needed because at different times people will need different things. But one of the biggest pieces with the future of the doctor's role is that we're going to have to do 2 things. We're going to only see the most complex patients, and then we're going to have to manage teams and be a consultant to those teams without the direct interaction of the patient. And a quick anecdote to that: when I worked in the clinic, one of the things that we had, I worked with physician assistants. We had physician assistants paired with therapy providers, and one of the things that we started with is I said, you know what we should do is I'll do the intake with the patient, do all the deep dive medical history and evaluation, come up with the plan, and then once we implement the plan, then I'll hand them off to one of my PA teams. Well, the problem is that because of that early life trauma that these patients had, the minute that I, quote, handed that patient off, they felt abandoned. And it failed miserably. They were splitting between the PA and myself. They were frustrated. They would get angry. But the minute that the first person that they saw was the physician assistant in that team, and they were assigned to a team and not a single provider, then I, as a physician, was brought in really only when they needed my specific expertise in either addiction or pain or just the extra knowledge that a physician gets with that extra schooling. But that's really only about 10% of the things that they needed. And just coming to the realization that our actual scope of practice is, while wide, really needs to be narrowed to the most complex issues medically with the patient, and really helping to run and lead teams of people. So that's the conversation, is just the changing scope of physicians. And it is a little tough on the ego, but if you continue to I find it harder to deal with physicians than I do with the most complex of patients, to be honest. But as we start to move in that direction, all the chief medical officers that I work with in doing this, it really comes down to embrace the fact that you have a high level of knowledge, and that people will always need a physician for that skill set, that capability to deal with really, really complex medical situations. And we're not just going to be able to sit around and look at ears and see if they're infected or, you know, treat the cough. We need to be okay with this. So empower that uniqueness at the same time without feeling like somebody else is encroaching on it. And it's a slow process, but it can be done.
Okay, well, thank you for that, Corey. Great insight. A related question, and I'm not going to be able to paraphrase it very well, so I'm going to read it. This person works regularly with health systems, promoting the concept of practice redesign and incorporation of multidisciplinary approaches in patient care, and commented that moving the conversation beyond role definition by, quote, job description only has been difficult. I.e., health systems say we are already providing team-based care, and clinicians are not willing to give up aspects of current work that may be more appropriate for other providers to take on. Any suggestions in facilitating these early conversations? Also, how can we adapt our medical and allied health education system to promote building of skills needed for team-based care? So 2 questions there. Any suggestions on facilitating those early conversations? And do either of you, Catherine, I'll include you on this, have any ideas on how to adapt the medical and allied health education system to promote building of skills needed for team-based care?
Yeah,
so Corey, maybe you first on that first aspect, and then both of you on the second.
Sure. So the first piece is if you take the job description and you put all of the job descriptions next to each other of the list of things that I talked about. Let's see if I can get back to that slide. If you put the job descriptions next to all of those people listed under medical care, care coordination, therapist, social connectivity, home-based interaction, you'll find that there's actually in those job descriptions an appropriate level of overlap. And if you can imagine a pie, and people divvying up the piece of the pie that they're the most expert at, knowing that they have skill sets in other areas, but there's someone else who is more expert in that area. So if it's getting accurate information about how the patient is really feeling, it's not me. I want it to be. I wish it would be me, but it's actually the community health worker. It's the person who they'll talk to, that they trust, that they have that interaction. So the conversation can even start with the description of the roles, that their job descriptions have. But then the other piece is for people just to realize that patients don't need a better or more of a prescription. Many times they just need someone to help guide them through the system. And whether that be emotionally in the case of a therapist, or logically or coordinated pathways in the case of a nurse or an LPN, then that's fine. But either way, those things overlap a ton. And so the key is to focus on the areas in which they have the highest level of skill and be okay with letting other people do it. And that's the best way to start that, is to realize, fine, everybody needs to work at the highest level of the scope of their practice. And let's see where we can benefit by overlap.
Yeah, and this is, Catherine, just one additional thing I might add to that first piece. I mean, Corey's really the expert here, but one thing that IHI finds as we're working with health systems around the world to make some changes like these, is this concept of starting small can be a really great way to kind of address some of the initial resistance. So if that was something that you were hearing as you were trying to start this conversation, maybe even saying, well, let's just try this approach with, 5 patients, and then do kind of a PDSA, or, look at what happened there and make any adaptations that you need to based on that small test of change, and then grow there. It can be a really great way to build will around change. So I just wanted to add that in.
Yeah, that's
I
really
wonder,
important. Really important.
oh, go ahead, Corey. Sorry, I didn't mean to interrupt.
Oh no, I mean that's it. I mean, I think that's a really, for culture change, you can't start big. It actually has to start small and spurt organically, and take some time. So that's a really, really good point, Catherine.
Yeah, so I was going to add, I wonder if there is a degree of, and I've never worked on the front line, so this is more of a question of, seeing maybe just a modicum of success from a small group of patients in sort of a pilot phase, if that'll do more than any other sort of lecture or educational opportunity to just sort of give, different providers a sense for what this could mean for a patient and see that from the front line. It's just a little bit of a taste of success that will sort of encourage providers to be more open and to do more.
Yeah, and I think also to make sure that you're not telling a provider that this is what they're going to do. You're asking, and what you'll find is there's a subset of providers who really want to work in this capacity, and some don't. And I have found that trying to force somebody into this system is just bad for patients. So if they just want to work alone and they want to see patients by themselves, that's fine. Just funnel the patients to them that are less complex and don't need multidisciplinary teams. Like, I don't need a multidisciplinary team. I just need to get what I need. And I don't care who I see if I have to go to my primary. So, I mean, there are a lot of people in that same boat. So it's also about matching the right patients to the right providers. And those patients that need multidisciplinary teams really do deserve providers that want to work in those teams.
Yeah, agreed. Before we get to the education system aspect of that question, because I think that's an important one, Catherine, I want to come back to you, and you have a comment about sort of responding to the earlier question about an anecdote of a provider using the playbook.
Yeah, thanks, Tom. And interestingly enough, it was actually reading through this question that got this pop back in my mind. So I'm sorry I didn't remember it earlier. But one kind of very interesting use of the playbook that we didn't really see coming is we were approached by a school that was working on their curriculum development for their nursing program, and they asked if they could use some of the content for the playbook in their curriculum development. And I can't claim to be an expert in the medical and health education system, but I think that that is just one example of kind of adding this content in at an early stage as our health professionals are kind of in their initial training. It seems to me like it would be a really good step in building the skill for the future.
Yeah. Corey, did you have any thoughts on the education system aspect of that question? What can how do we adapt medical and allied health education systems to promote building of skills needed for team-based care?
Yeah, so I think that the first thing is the same vocabulary. That's one of the biggest gaps, is that I realized when I first started this, that the way in which I describe a certain disease is actually very different from the way in which a social worker describes a disease. And even a nurse or a community health worker or, an administrator. And so having the same vernacular and vocabulary to describe the disease is important. And that's why people getting their training in the same place is really of the utmost importance when it comes to team-based care and that. So for like the website, and I think somebody asked how to get there, the website is www.complex.care. And again, I should say as a disclosure, I get no income from this. It's free, so nobody gets any income from this. But but with this, the goal was also to have videos that interdisciplinary teams can watch together, so that they can have a discussion and they can do it. And so if you really want people to learn to work together, they actually have to have some capacity to learn together. And I would point to Jefferson University Health System in Philadelphia, because they have developed a really robust interprofessional and interdisciplinary training program where medical students, nursing students, law students, population health students all end up working together on teams and learning together. And so there are already models that exist for how to do this. And I think that model, quite honestly, would fit into any health system as well.
Okay, great. Thank you for that, Corey. A question related to what you just shared is, how can we access the education resources referenced by Corey? I'm referring to the 7 Archetype Patients platform. Is that on complex.care?
Yeah, so on complex.care right now, we have a little over 12 hours of education. It's in its late beta testing phase. We have another technical update that we're going to be doing in the next 6 months. It'll have 14 hours of information on it, which if anybody knows about CME or CEUs, I mean, 14 hours is a ton of information. When we fully finish the curriculum, it'll have 90 hours of curricula on there. And so you just go to complex.care, sign up, and it'll build your curriculum based on what your stated education level is. But you can freeform it and just look around if you want, but it'll also build you a dashboard. And
great. Yeah, just a really great resource. Probably should take this opportunity to clarify that the URL for the resources that Catherine highlighted, the playbook, is bettercareplaybook.com. And we highly encourage everyone that attended today and everyone that didn't, who will be watching this later on, to go and explore those resources. Just an amazing group of work that has been done that we just really felt the need to share with everyone here. So with that, we want to thank Catherine and Corey for your insight and perspective today. Thank you both for being here.
It was my pleasure. Thanks so much for the opportunity.
Yeah, thank you. There was one more question. Do you mind if I just quickly answer that in 30 seconds?
Oh yeah, go for it. Thank you.
Yeah, I saw that. What is on pharmacists playing a role in the team? And I think that the reason it wasn't listed on my sheet is just because it was so hard to actually get somebody to pay for one. But the reality is I think that they're a fundamental part of that team, and especially for these patients with very complex medical regimens, and many times resistant bacterial diseases and antibiotic regimens that are required. A lot of different metabolic issues to think about and deal with. So having access to a pharmacist is actually critical to safe care for these really complex patients.
Thank you, Corey. I'm so glad we were able to slip one last question in there. So thank you to everyone that has joined today. Just a reminder that an audio recording of this conference will be made available and will be included in our weekly news summary. A reminder that September 6th will be our next webinar with Brent James on integrating capitated payment arrangements in ACOs. So if you have any questions about the ACLC or follow-up questions with this webinar, please email members@accountablecarelc.org, and we'll be happy to address your questions. Thank you one more time for joining us, and we hope you've found this presentation worthwhile. Bye, everybody.
Bye. Thank you.